write them in the chat box, and we'll try to get to them. So we want to welcome you to this webinar, the 1 year mark, what works for GBV program adaptation. And I want to thank InterAction and the members of the organizing committee for organizing this, and we will get started. So as I mentioned, I work for Refugees International, and I'm going to kind of set the stage and give a few comments and frame the conversation, and then we'll get to our panelists. So gender-based violence has long been a threat to women and girls around the world. 1 in 3 women worldwide experiences physical or sexual abuse in her lifetime. Violence against women leads to as many deaths among women of reproductive age as cancer. While anyone is at risk of violence committed against them because of their gender or perceived gender, women and girls, including trans women and girls, experience disproportionate gender-based violence, which results in more negative health outcomes worldwide than traffic accidents and malaria combined, and we can consider this an epidemic. This level of violence is also a key element of gender inequality. These concerning trends demand that donors, governments, and humanitarian organizations dedicate funds and commit to urgent action to better protect women and girls from violence during especially this global health crisis. However, taking those steps first requires thoughtful gender analysis, which is a tool providing essential information about gender roles, responsibilities, capabilities, and vulnerabilities. So we need this to understand what is driving the increased risks of gender-based violence and how they are taking shape differently because of the pandemic. Shining a light on the changing nature of the problem is the first step in determining how to best counteract the factors which lead to gender violence and therefore mitigate its increase. Much has been done to try to address gender-based violence amongst global actors, but governments, donors, international organizations, non-governmental organizations, and communities must take further and more creative actions to combat gender-based violence, particularly during the COVID-19 pandemic, in which we've seen the risks to gender-based violence increase dramatically. And these organizations and global actors and non-governmental organizations have been doing so. So now, more than a year on, well, just about a year on from the start of this pandemic, we want to look back at the lessons learned and look forward to what must be done now to stem the tide of this problem and effectively protect women and girls around the world. So some of the folks who are doing this work and who, like I said, are taking on addressing these risks and addressing gender-based violence are with us today. So I want to turn to the panelists who really have this expertise to help us figure out how to do this, how to address gender-based violence, how to learn from the lessons that we've gained in the last year during COVID-19, and how to move forward effectively. So I want to introduce the panelists. Today we have Happy Ainomugisha, who is a program manager with Action for Development. She is responsible for coordinating interventions on GBV prevention, both in refugee settings and in host communities. She is a strong believer in collective effort and strong coordination for ending violence against women and girls. Action for Development is an Indigenous, voluntary, non-governmental women's organization with vast experience in promoting women's rights and gender equality in Uganda. ACFODE envisions a just society where gender equality is a reality, and Happy's mission is to empower women, girls, and influence legislation and policy for gender equality in Uganda. She's a strong advocate that gender-based violence prevention and the elimination of all forms of violence against women and girls is important. Her organization is also building local thinking, is also a building local thinking global partner in Uganda with the International Rescue Committee. We also are lucky to have Bryar Mohammed, who is Women Empowerment Organization's Director of Programs that is working across all of Iraq. He is an experienced project manager in diverse humanitarian programs, including women's participation, livelihood, education, youth development, protection, and GBV projects. He also holds an international certificate in quality management from an ISO. Women's Empowerment Organization, an Iraqi national NGO that works to promote equal rights for women to ensure their fair participation and inclusion in the Iraqi community. WEO's strategy is to empower women economically and politically by helping to end all forms of GBV and advocate for policy reform that addresses gender equality and the adoption and implementation of international resolutions and conventions. Since its establishment in 2004, WEO has been working across Iraq and providing services in 4 main sectors: livelihoods, humanitarian response, protection, and advocacy. And finally, we're joined by Micah Williams, who is a gender-based violence specialist focused on addressing GBV in humanitarian contexts. Since 2010, Micah has served as International Medical Corps' Senior GBV Advisor and Technical Lead, supporting the design and delivery of GBV prevention and response programs in more than 25 countries across Europe, Asia, the Middle East, Africa, Latin America, and the Caribbean. She leads the GBV AOR, Managing GBV Programs and Emergencies, multi-phase learning program, and has contributed to many technical resources for GBV prevention and response programming. Prior to her work with IMC, Micah worked with various NGOs, the UN Department of Peace Operations, the US Peace Corps. She managed and coordinated GBV and sexual reproductive health and rights programs, and also worked in the field of human rights as both a survivor's advocate and an investigator. Micah has a master's degree in international relations focused on gender, human rights, and development, and a master's certificate in international conflict resolution. So, as you can see, we have a really diverse and amazingly experienced panel that we can learn a lot from, and I'm just excited to turn it over to them. So the first question I want to ask is, this webinar is really taking place pretty much exactly a year since the pandemic started, since lives changed for all of us, since we all got locked down. And so I want to ask each of you, what did you change, and did those adaptations go the way that you thought in terms of your programming? So maybe we'll start with Happy.
Yes, thank you very much, Devon. As earlier introduced, my name is Happy. I work for Action for Development in Uganda. And of course, like any other country and like any other organization, the pandemic had its impact on our interventions as an organization, but also as GBV actors, as we operate in the different settings, as earlier mentioned, the refugee setting and the host communities. First of all, when the pandemic hit, of course, the country was locked down, and there was, of course, restriction on movement. We could not continue with the interventions that we were supposed to do before the pandemic. And as an organization, we had to adopt and embrace technology in terms of keeping in touch with our field team, keeping in touch with all the other actors in the fight against violence against women. So we had to embrace, while working from home, the Zoom meetings, the team meetings, the intensive phone calls, continuous emails, so that the organization keeps intervening even when we are not there physically. And also, secondly, what the organization had to adopt to was utilization of community focal persons. They are community women and men that we have been engaging with while implementing the different interventions where we do our work. So this was the time to really step up and continue and strengthen our community networks, our community frontline communities in responding to the pandemic, of course, while observing the SOPs, while ensuring that they are safe, wearing masks, social distancing, but also keeping in touch with most of our target groups in the provision of the services. by our target groups in the communities where we were working. And also adaptation to the smaller space meetings. Of course, this was the time when larger meetings or larger gatherings are not allowed due to the restrictions, but also due to the SOPs that were being put in place by the Ministry of Health here in Uganda. So as an organization, we had to redesign our interventions to make sure they fit in the available health guidelines that were provided by the Ministry of Health. So instead of meeting 20, maybe to 30 people, we had to resort to 10 to 15. But of course, ensuring everyone is provided with PPEs, ensuring their hand washing facilities, ensuring that everyone is sanitizing, equipping them with information so that they are able to go on and also share, disseminate, and also distribute information regarding COVID risk mitigation, but also the associated risks with it concerning gender-based violence. We also had to resort to intensive media awareness campaigns, right, of course, from engaging on radio, of course, but we do recognize that communities, not everyone has access to radios. So we had to also integrate other interventions like use of local mobile vans that move from village to village, that move from community to community, creating awareness on the pandemic, creating awareness on the risks associated with it, creating awareness on the acceleration of the gender-based violence, of course, cases at community level, creating awareness on the likely risks that might impact on the adolescent girls, those who are now out of school, but they are now confined in their homes, and also those ones who are already at community, also already in the communities. And also, lastly, what we had to really integrate as an organization is to make sure we integrate self-care sessions, of course, with support, technical support from the International Rescue Committee. As GBV actors, of course, were affected by the pandemic, working from home when you also have other roles and responsibilities, but also to keep the workspace in a home setting. I must say that it wasn't also easy, but we integrated the self-care, the wellness and safety sessions regarding how to handle some of these cases that are coming in, and also to make sure that we keep the pace of providing the best and quality psychosocial support to our target groups at community level.
Thank you so much, Happy. That's really important information and really interesting ways that you adapted and also had to take care of yourselves. And I think that those are good lessons for everyone. Bryar, I want to turn to you and hear a little bit about what your organization changed with the pandemic, how you adapted, and how those adaptations worked for you.
Okay, that's great. Thank you so much, Devon. Hello, everyone, and welcome. I want to start with that. Some of the points that Happy mentioned were the same things that we did because we had access to the clusters all over Iraq, and there was like international solutions. There was a lot of coordination between the international and local organizations to exchange what are the best ways to mitigate the risks of COVID. But what we did significant, we were having like a GBV program at the time, and we were providing multi-sectoral services like PSS, legal consultation, GBV awareness, and case management, cash flow protection. We had those services at the time of when the COVID started. At the beginning, we were not affected as much as the other countries until like the middle of March. When we started there, then there was a strict lockdown forced upon us, like a very strict lockdown. And this lockdown it cut our access to all the places that we were working in, because the government would not even let us go out. Even they wouldn't like let anyone go out. They wouldn't give anybody permission to go out. So what we did there is we started an online campaign so that the GBV survivors in the areas or that we were targeting, we started like with the phone messages, WhatsApp messages, social media campaign, TV, campaign, which we tried to reach out to them and see that, to tell them that we have these services that we're providing, and if anybody knows anyone and how to refer them, then we did a few online sessions on how to refer these cases to us. What are the safe referrals mechanisms that you can use for when you notice a GBV survivor in your community? This is something that we did, that we benefited from, because we did not have access to the survivors of GBV for almost a month and a half. Then the lockdown stopped here. They didn't take much. The lockdown, they stopped it, and then people could go out, but we still did not have access to some locations. One thing that we really benefited from was that in one of the camps that we were uh, operating, we had the social workers and the case managers from inside the camp, from the community themselves. This was something that in that specific camp and in another camp that we were working, we did not have any problem with delivering the services. The only thing that were hindering us was that the camp, there was like some prevention measures for COVID, which we were already doing. We just provide them with sanitary materials, masks, and social distancing and this kind of stuff. So we could easily have access to those, and we have communicated this point with all our partners. And we even in the areas that we did not, we had the social workers or the technical staff from somebody else. We tried to hire more staff close to the community so that we can deliver these services. So this is true. And then the community action groups that we created at the time, we were doing GBV awareness, and in each GBV awareness session, we created a community, a network in between these, how do you say, like these targeted communities. We created committees, action group committees, or these community action groups, or whatever you name it. These were the focal point for referral for us, so that we could deliver our services online, even though the quality of the services online was not as we expected, as we thought that it would be, because the women or the GBV survivors at the time, they were having this issue of the perpetrator being inside the house while they're trying to call us, or while we tried to call them, and there was they could not talk like freely. They could not talk about what's happening exactly. Most of the time, they wouldn't even have access to phones, especially in the refugee camps, because we work in refugees, IDPs, and host communities. The host communities access was easy through phone, but then again, we had some things that were challenging, which was the existence of the perpetrator inside the house that we could not overcome. So instead, we just tried to deliver as much as possible until the end of the lockdown. Then we tried to reach out to them face-to-face, because we realized that the quality of services are endangered. How do you say, like it's compromised when we are doing online sessions. Even in the awareness sessions that we were doing at the time for GBV awareness, we were not getting as much engagement as we wanted from the community leaders and the tribal leaders that we were doing GBV awareness to. So at some point, we just stopped doing the GBV awareness. We tried to do the TV and media campaign instead of that until the lockdown. After 2 months, they stopped the lockdown, and then we could have access to them, but very small numbers each time because of the prevention measures for Corona. This is technically the things that we did to adapt to the lockdown that happened due to COVID, and about what I think worked. The only thing that worked like really good was that getting people inside the camps or the communities that have easy access to the people, so that we ensure that the quality of our services are the same quality that we were providing before the pandemic and during the pandemic. One other challenge during the pandemic was we did a GBV assessment all over Iraq, to know how are the cases how the cases have arisen, what's happening inside Iraq during the pandemic, because there was like from official government or establishments, they were saying that the GBV cases have decreased during the Corona, and it didn't make sense to us, because honestly, when the perpetrators are inside the house, I mean that there will be cases when the people are locked inside one house, and then they have so much time together. They have a lot of livelihood pressures, a lot of the government did not give any livelihood opportunities for the people, or they didn't give them any money in compensation for that. They have been locked inside their houses. So we still thought that the cases have arisen, and when we did the assessment, we realized that it has actually it is more 60% more than what it used to be before the pandemic. And that was one other problem, that the cases could not access the government and non-government associations that were based for, or that were providing GBV services and case management and shelter. They couldn't even access shelter, the cases. And the government cut a lot of funds from the Directorate of Combating Violence Against Women. The donors cut a lot of funds during the pandemic because it was very risky, even for the donors. Even the programs that we applied for that were very necessary for the pandemic, we did not get the answer in time. For example, I've applied for, our organization have applied for a project, a proposal for GBV programming during COVID and recovery after COVID. It's a 2-3 year program, and we still have not received the answer back. So because even during the pandemic, it was something that we were not ready for, but then again, and the donors and the people, let's say the donors, they still took the same time to process the proposals, which created another challenge for us. Overall, this is all I have to say. What we did is an adaptation, what actually worked, and what were the other challenges that we faced. Thank you so much.
Thank you, Bryar. That was really helpful and really interesting. I think one of the things that both you and Happy said was that one of the most important things you relied on were community workers and people within the community to access the people you needed to access. And I think that is really important. I also think your point about the donors not getting, not necessarily getting back to you in time and having, projects for emergency COVID response and perhaps not responding in the timely manner you needed was interesting as well. I want to turn to Micah. And Micah, working at the global level, I think, will have some interesting insights for us. And I want to ask you, Micah, because you've been involved in some of the global level work to adapt the guidance for both IMC and the global, provide some of the global guidance, what are some of the overlaps and commonalities you've seen between the global level response or IMC's response and the responses that Happy and Bryar mentioned? And did you receive any feedback about these global guidance, about the global guidance and how it was being implemented in the field?
Thanks, Devon. So yeah, I can talk a little bit about the guidance that we developed through different interagency coordination mechanisms, and also speak a little bit to IMC's programs. I definitely see a lot of common work between what Happy and Bryar described to our own programming. I think one of the things, there were so many things about the pandemic that were pretty unique to our experience with humanitarian programming. I mean, first, that it was happening everywhere at the same time, and that it didn't just affect countries where we were providing services, but also countries where, for international organizations, where like technical staff and people might be based, so they weren't able to travel and provide support. So a lot of those people, like myself at the global level, were busy trying to support remotely and working on some advocacy papers, working on some global tools and guidance, because it became clear really quickly that all of these programs and services around the world would need to do some really quick adaptations. So just trying to support as much as possible. And I think, that work involved for us, for me, I was really focused on involvement where the guidance related to support to service provision. So looking at how survivor support services could be safe, how we could continue to meet with women and girls and provide information. So some of what both Bryar and Happy talked about. And also, as part of that, one of the challenges was also to do some of the advocacy work around, why these services are so important, even more important during this pandemic, because it might not be immediately obvious to all audiences that the pandemic would accompany an increase in GBV, particularly domestic violence. And then within that, to sort of address some of the maybe misperceptions or some confusion that was introduced, I think, pretty early on. For example, pretty early on, there were suggestions from different corners and kind of just acknowledgement or this idea that the services would need to close, that in-person services wouldn't be safe at all. And so we saw in many settings, people were quickly closing women and girls safe spaces. They were quickly shutting any type of in-person GBV case management services. And we even saw in some of the early advocacy notes indications that this might be appropriate. And also some suggestions that services could be shifted to health facilities that would remain open throughout a pandemic. And we found that pretty problematic from our own programming experience, as well as other organizations. So for example, both IRC and IMC, we've worked with GBV programming through the Ebola outbreaks and realized through that experience that women and girls weren't visiting health facilities as a good entry point or a service point for GBV response services because of the associated stigma and risk. So we felt that that would likely be true with this pandemic, that wouldn't be a good place to rely on service provision, but also that you don't want to further overwhelm the health facilities. So instead, we wanted to look at how can we actually advocate for keeping places like women and girls safe spaces open and possibly even relieve some of the burden from the health facilities by advocating for like well patients to do family planning consultations, or to remove some of that work from the health facilities and put it into the women and girls safe spaces if possible instead. And that provides further justification for keeping those centers open. So one of the early pieces of guidance that we developed, IRC, IMC, and NCA, we worked together on a women and girls safe space technical note. And that talked about how to adapt women and girls safe spaces and how to stay open through different stages of the pandemic, understanding that this is really related to like the different government restrictions that might be put in place in terms of what's shut down. There's a big piece that was missing pretty early, and it took a long time to come, was the advocacy for frontline GBV response workers to have PPE, to have protective equipment. I think even internal to our organization, which is an international organization, this took work for us to make sure that we are prioritizing social workers and people who are in direct contact with survivors as essential workers in the sort of first tranche of people to get these supplies. And I think that that was information I was seeking early on about local organizations, whether they had any access to things like masks and sanitizer. Because there's one thing to be ordered to shut down a center, it's another thing entirely if the staff feel even comfortable or safe to respond. One of the other things that we found was really important was starting to kind of tease apart the different services that might be possible, the different adaptations that might be possible. And I know the other presenters spoke about some of that. We knew we couldn't rely entirely on technology. So again, the importance of maintaining in-person services, how to make those safe, because even where technology is available and even where women have access to it, we found that through case data during different stages of lockdown, women weren't calling for help when their abusers are home. So that the sort of remote phone-based service wasn't a full answer for us. And we needed to separate the types of services and provide guidance on how to provide each of those. One of the confusions, I think, came with this idea of just introducing like signal alerts or entry points, you know, that we can do that, that we can find these survivors through all sorts of safe means of sharing information. And then they signal that they need help in these creative ways, you know, through the health center or by hanging a flag outside their home or something. And that might be great, but there needs to then be a service that follows. And so we kept coming back to, we need to be able to make these services safe. So the guidance really centered around the in-person services, making those safe, also what phone-based case management services should look like. So we worked with IRC UNICEF, UNFPA, UNHCR within the GBV IMS steering committee to develop guidance for adapted GBV case management services, and also looking at possibly hotline services as well. And then there was an additional piece of guidance that involved lots of organizations, also CARE, TroCare, and all the UN agencies, the GBV IMS steering committee, on more specifically on the remote services. So not the in-person, but looking specifically at the remote GBV case management services and also hotline services. We saw a lot of confusion early on. I think this is still happening, where people talk about hotline services as a way to provide GBV case management. And while hotline service is not just an entry point, it is a service because we can provide counseling, like crisis counseling and referrals through the hotline. It's not the same thing. And we really need to make sure that we're prioritizing as much as possible the holistic support to survivors that we know is best practice, and that those services should be considered essential. So I can share links to the major pieces of guidance that I contributed to. These were largely shared through the GBV AOR community of practice. And with PRM support, IMC helps to administer that community of practice. We saw within the year of the pandemic, the participation in community of practice, which is only for GBV practitioners, mostly in the field, overwhelming majority are in the field, that we doubled in size from 400 to almost 900. And a lot of exchange in resources through the community of practice. We created a whole online library where people were able to access like gray literature and tools for people trying to do adapted group discussions or interventions. And we've held webinars throughout the pandemic through the community of practice as well. There's another one this Thursday where practitioners are going to share some of their experiences providing remote services. So I can share the information and comments about all of that. And I hope I answered your question.
Yes, you did. Thank you. You answered the question really well and gave us a lot of good information, and especially the community of practice. I think, thank you for sharing the information about Thursday, and we will, through the chat, either through you or Anna, we will certainly share the information so that practitioners that are involved in this conversation today can also get involved with the AOR and have more guidance coming. I want to move on to, I want to go back actually to the reflections on adaptations. So each of you spoke about adaptations, both within your own organizations, and then Micah, as you mentioned, just kind of the guidance on how to adapt and how to best adapt services. Bryar, you talked already a little bit about something that worked. If you can each talk a little bit more, we'll start with Happy, about adaptations that you made that worked or worked relatively well. And what I'm most interested in is, the pandemic is going to subside or change, and we will get back to a more normal way of operating. And in doing so, what are some of the adaptations that you've made that you think you'll keep, that you think add to your service provision rather than are just an adaptation? Happy, if you can answer that, that would be great.
Thank you so much. Yes, some of the adaptations that we shall keep as an organization, one is to utilize, strengthen, and continue using the community networks, the frontline groups in communities. One of the key approaches that ACFOD has used for the previous years and has proven effective in GBV prevention is the model couple approach, where we work or train model couples in GBV prevention, and also a basic counseling technique within their communities, within their household, so that they are able to pass on the information, to pass on that counseling technique to another couple. That is an approach that has been used by Action for Development in other areas, even before the pandemic. And when Corona came, we felt this is something we need to really intensify and utilize it in communities and make sure that these groups live within these communities where we work. So even if we are unable to reach the communities physically, these community networks or groups or the model couples will still pass on this and also offer referral to the survivors of gender-based violence. Secondly, an adaptation that we'll have to keep on is utilization of the local awareness campaigns, making sure that the information keeps flowing even when we are not at community level, even when we are not having physical interactions with the target groups. But the awareness campaigns, the dissemination of information, the dissemination of the risk, the COVID risks, the mitigation measures keep flowing in the communities. One, by utilizing the mobile funds that move from community to community, use of local motorcyclists with recorded information that talks about the impact of this, the challenges associated, but also offering, giving them information in case there is a challenge you're facing, especially for the GB survivors. Where do you quickly get the service? Which numbers should you call? Which offices should you reach? Even if there is a restriction on movement. And thirdly is, of course, the use of household visits. When the easing of the lockdown started here in Uganda, we adopted the methodology of household, house-to-house visits, of course, providing with the information because the communities were still in denial of this pandemic. They were not understanding why they are being locked down. Maybe they thought this pandemic is for the urban dwellers, but not for the communities. So we kept giving this information through our field staff, and they were doing this through household visits, of course, observing the standard operating procedures, wearing the mask, sanitizing, and making sure that the groups they are targeting are not beyond 5 to 10 groups of people. Those are the key adaptations that we really intend to carry on, even as we continue doing this work, as well as making sure that the information keeps flowing, targeting especially the adolescent girls. In our assessments that we have done in our field interactions, is that there is escalation of teenage pregnancies, early marriages, of course, with the shutdown of schools. They have nothing to do. They are confined in their homes, and of course, trying to access some of the services, trying to do their house chores. Of course, some are being defiled, some are being raped. Some of the parents are forcing these girls to enter into marriage so that they can get, something for survival. So there is a lot of teenage pregnancies. When you look at the numbers from March, the assessment that was done from March to September, October 2020, the numbers are alarming. And even with the girl chats that ACFOD engaged in with the adolescent girls, it is something that we really need to pay attention to, organizing those safe spaces for for adolescent girls and also the women, and continue talking about the impact of this pandemic to their well-being, to their lives, and also, of course, giving them hope that maybe the easing of all these services will continue being eased slowly by slowly, so that they're able to go back to school and also resume their normal routine in terms of accessing education services. Thank you.
Thank you, Happy. That was really comprehensive and gives us some good best practices to go forward with. Bryar, can you speak to that as well, to what adaptations have worked and what you plan, what you're likely to continue doing?
Yeah, definitely. Thank you so much. Well, to be frank, the only thing that worked best was elevating the lockdown. The lockdown was no more there, because depending on different communities, we were trying different approaches. For example, when we wanted to target the host communities, we were trying to use social media or mobile platforms to get to them. They had access to internet, they had access to Zoom meetings, they had access to Google Meet. We could provide psychosocial sessions, the psychosocial support sessions. We could do that. These things we could do with the host community, but we could not do this with the refugees. We could not do this with the IDPs as well. So what we did for the refugees inside the camps, refugees and IDPs inside the camps, were the community action groups. The community action groups that we created that were, how do you say, that were trained on safe referral and how to deal with cases when they receive cases and when they think that there's one case inside their community, how to report this, how we can deal with this. Like Happy said, like utilizing these community action groups was something that really helped us, and we did that before even the pandemic. It was just something that we were benefiting from, some activity that we did. We didn't even know that there would be a pandemic. We just got lucky. To be completely honest, we just got lucky there because we had community action groups. Then when the pandemic happened, we said, like, why not utilize these people? Because they're already working close to the community. They already know each other. These are tribal leaders. They're religious leaders. They're community gatekeepers. They're influential people. Why not? So we just trained them again. Just remind them on some basic points that they needed to know. This worked very well for us. We could reach out to a lot of like survivors at that time. This is for inside the camps, even outside the camps as well, but especially inside the camps when we were dealing with the IDPs and refugees inside the camps. So, and this is one thing that worked very well. The other thing that worked very well, I said before, is that we had to hire people inside the camps or inside the communities close to the people, so that they could actually have access to people. Because our biggest issue during the pandemic, there was two big issues. The biggest one was the corona, and the second one was the access. So the COVID virus, we were very, very careful with all the social distancing and prevention measures, because the safety of the frontliners were one of the most things that we had to focus on at the time, because at the time, nobody really understood the virus. Nobody knew how it works. So it was very dangerous. Even the staff that we were hiring, they were hesitant of working inside the communities, because they were afraid that they're going to get this disease and they might die, and they don't want to work in that. So there was so many challenges, but overall this worked for us perfectly with taking the needed prevention measures for COVID-19 and ensuring their safety. They could have access to people for case management, for psychosocial sessions, but we had to be very, very careful and only target small groups, which this created another challenge, that is the cost of these activities were actually more than it was planned, because we didn't want to do it online. Some of the organizations did it online, but then we had to be very. I have a background in quality management, and this was something that I utilized there. I was very, very, very concerned about the quality of the services that we're providing. We wanted the quality over the quantity. So at that time, we didn't do anything online unless there was no other way. This is what we did, but there was more cost to it, because we had to get small groups into bigger locations that you have to pay more for the venue, and we had to pay extra for the whole prevention materials and the hygiene kits and everything. This is something that we did, but overall it actually worked very good. This is something that worked very good. And as Happy said as well, doing the media campaigns and raising awareness, I think that was something that worked as well, because at the time people were very, very much busy with social media and media at all, because they had a lot of time. People at the time, they had a lot of time at home, and then this way they could actually we could target them on social media or on TV, even though like there were other problems coming from them being home, as I said, because there were no support from the government. So but overall they had access to some of those, and we could benefit from the campaigns as well. I'm not going to say that the online sessions did not work, but we all know that an online session, it decreases the engagement, especially from people that are not very IT oriented. This is something that we have been facing this problem since the beginning of the pandemic, because people do not understand, they don't have the technological background. We don't even have a good technological infrastructure in Iraq. Like up until now, people that the students in the let's say the students in school, they have problem because they don't have two phones in the house for two brothers to attend the same course. And there was this, and there was others. We didn't even have the technological infrastructure. We didn't have the internet infrastructure. We did not have it. So I'm not going to say that it didn't work, but we preferred not to do it, and we stayed away from it as much as possible. Because sometimes we would do some sessions, we would send someone a video, it's like, you can watch that video. They would just rather go do something that's entertaining than watch something that is that has a positive message. This is why we were trying to avoid that. And as I said, but the one-on-one session on the community groups, this is something that really worked. This is what we experienced through the pandemic. If we're not talking about what was past, but still we have the lockdown is over, but we still have some challenges that I think that's our next topic. So
I was going to say, perfect segue to the next topic, but I think you know, some of the things you said clearly demonstrate that there's adaptations that can complement what you want to do, but they're complementary. They're not substitutes, it sounds like. Micah, if you can speak to this as well, you know, what are some adaptations you think you'll likely keep, you know, through IMC or other means after the pandemic changes?
I mean, I think I don't want to repeat the answers that were given. I think much of what's been so exciting actually to see is just the real creativity and flexibility of the teams to think about ways to get the work done. Definitely ways to provide information to vulnerable people, to connect people with service providers. It's been really inspiring. I think even at the global level, it's been inspiring to see so much collective goodwill between organizations to really just work together quickly to get guidance and materials and advocacy notes put together and out to the people who need them, and all of that done without the sort of, you know, branding or money or any of it behind. So I want to keep that for sure. I would also, though, like maybe to emphasize what this creativity, this flexibility that we've all demonstrated. I think sometimes the message is lost about the importance of the critical services, because GBV is multi-sectoral, even the response is multi-sectoral, and because we offer so many different things, because we do so much awareness raising and social change work, and because we focus so much on coordination through other sectors to mitigate risk, it can look like GBV is covered. Like, you know, well, we're not able to deliver those services right now, but the teams are still active. They're still doing all this important work. So it's fine. We'll just shift the emphasis from one activity to another. And that's not okay. And we saw, you know, from some corners, people sort of suggesting that, people being okay with that. And I think it's really important that we keep our focus. If we believe that every survivor of GBV deserves individual support services, and if we believe that the best way to deliver those services is through a case management approach that requires a one-on-one service provider survivor relationship, where the caseworker is able to help the survivor navigate through her choices and make decisions about the services she wants to receive, and provide ongoing psychosocial support to improve well-being and safety in the process. That is the approach that we want to see, and we can't get, you know, creative to the point where we don't need the service providers. There are only so many ways to deliver that service. It's in person, or it's over the phone, or over an app. I mean, ultimately, it requires a relationship between two human beings, and there's no way around it. And so I think we really need to, keep that focus and make sure that there's attention not just to the risks and to the information, but really to how do we get these services delivered and how do we get the PPE and the money and everything that's needed into the right hands to make sure that the services continue and that they're safe, because they are essential and they are potentially life-serving. We've done a lot of work to classify them as such, and we shouldn't lose that message just because we're also capable of so much more.
Thanks, Micah. Thanks for reinforcing those points that we all need to remember. You know, like you said, Bryar, the next question I wanted to ask you guys is more about the continuing challenges, because the lockdowns, you know, have changed. I mean, most places are not locked down in the same way. So what are the continuing challenges that you faced based on COVID, and what are the support services and resources, the support and resources and financial resources in particular that you need to address these challenges that are continuing? Happy, we'll go back to you.
All right, yes, there are still ongoing challenges amidst the implementation. Of course, we know that Corona is still here, and we can't say that it's really out of our spaces. So one of the key challenge is not everyone has embraced technology. We feel, however much you organize, you know, these Zoom meetings, you know, meetings via online platforms, we still feel the physical interaction, the one-on-one we feel it is still important, even amongst, you know, the GBV actors. However much, you know, of course, meetings that bring so many people are still not allowed here in Uganda, but we feel that the online is not touch basing with the people you want to communicate to. So you still need that physical interaction. So embracing technology is still a challenge, and I think that most GBV actors really have to really step up and embrace all these different platforms to communicate what is going on. Of course, secondly, we know that however much we are utilizing these community-based networks and the frontline groups that we work with, of course, in terms of technology, understanding, the reading and having these gadgets are not there. So at times, if you want to really communicate via online platforms, it's not easy, and this necessitates, of course, an organization as an actor to really have to do physical interaction and one-on-one. Of course, we still know that Corona is here, and all those measures have to be really observed as we do this work. And thirdly, redesigning and replanning all the interventions. Of course, when the pandemic hit, our activities were based on our normal interactions, the normal conditions. But of course, after easing the lockdown, we had to quickly adapt, of course, to the current situation, but also redesign the plans, the interventions. Instead of meeting 30 or to 40 people at a go, you are now resorting to 10 or 15. That has, of course, a cost implication on the services that we are providing, and also adopting the house-to-house visits by the field teams. Of course, it also involves a lot of protection, a lot of provision of the PPEs, first of all to the group you're meeting, but also to the staff. So we still have those challenges in terms of having those PPEs in place for both the GBV actor or us as staff providing the service, but also providing that regular PPEs to the target groups that we are targeting in the work that we do. Thirdly, the flexibility of our development partners or the donors. It has also not been easy, and still not an easy slot in, you know, to include all these changes into the project implementation, into the interventions that we are doing. It's not very easy. So the communication, has to really keep on and justifying why you really need this in place in order to effectively implement what you had planned to do. Fourthly, or the fifth point, is on the high expectation from the target groups. Of course, we know that most of them were locked down for some months, close to 5-6 months. And of course, now revamping back and bringing on board, engagements, they expect high in terms of economic revamping, and they will open up and say, it's not all about, yes, we appreciate giving us the information regarding COVID-19, regarding the risk mitigation, but here you're telling us to observe hygiene, but we lack this, we lack soap, we lack water, we don't have the sanitizers, we don't have the masks. So the expectation from the community is quite high in terms of, continuing to give them the services. It's not really easy, but we are slowly trying to adopt it, but the expectation is still really high. And then the last point would be, of course, we do all this work aiming at targeting the behavior change. And this takes time, so it needs consistency. If you engage with a community network, if you engage with community groups, with action groups that we work with, it needs consistency. If you're there in a month, you need to again check in. After a week, you need to check in. You need to intensify those mobile psychosocial support services so that there is no gap again to allow the escalation of the GBV cases in the communities where we are working. So all these challenges are still with us. And of course, not believing that this is real, this is the new life that we are entering into. You find in most communities, however much you're providing these PPEs, they continue saying, I think it's not yet here. It is maybe with those people who, who stay far away from us. So we still have those challenges, but we continue to do information giving, of course, distribution of materials that are easily interpreted, and also continuous engagements with the different groups that we work with at community level, but it's not easy for us as actors. Thank you.
Yeah, happy. I can just ask a follow-up question. Because it's not easy and those challenges remain and exist and will for a while, what are the resources and support you as an organization need to address those challenges, to continue to address them?
Okay. I think as an organization, what we need to really do is to intensify our awareness campaigns, is to continuously provide information, educative, communicative, information that is tailored to the community that we are targeting. We need to continuously engage other community-based organizations, of course, within the refugee setting, but also in the host communities, in provision of self and wellness sessions, because as GBV actors also, at times you get worn out, of the calls that are coming in, but also even the in-house, challenges that as an actor go through. So we need those capacity building sessions, the self wellness sessions to continuously and regularly really happen for the GBV actors to keep the vigor of providing the services. And of course, we need the resources to strengthen our community networks, because they are willing, to keep the talk in the community, but at times you're constrained by the resources that we have as an organization, as well as provision of the PPEs. However much we are talking about social distancing, we are talking about sanitizing, we are talking about wearing the face masks and so on, we do not have those. We do not have all those, the PPE is in place, the equipments are not there. So if we can at least walk the talk, as we engage with the communities, we are able to at least provide some of these equipment so that they are able to continuously or mitigate COVID-19, the spread of COVID-19. And then also we need to at least have resources to mainstream and integrate approaches that target adolescent girls. This is a group that has been in school and it is now at home for all these months. And of course, some of them have been raped, some of them have been defiled, some of them have been married off, some of them have been implanted the teenage pregnancies. The escalation is really, really high. So as an organization, we really need support in terms of intensifying the campaigns targeting adolescent girls. And talking about the relationship between the pandemic and of course the impact of it on the case of adolescent girls. So we really, really need to focus on that so much because we find it a very big gap in the communities where we are working.
Thank you, Happy.
Thank you.
You said many things, and one of the things you said that Micah also said was that PPE is so important for the frontline workers, and getting that message across and to donors and everyone is really important. Bryar, can you speak to this as well? What are the continuing challenges and what resources do you need to address them?
Yeah, definitely. Thank you so much. So there are some, of course, there are some challenges that are continuous, one of which is the technology that I've written down. There is the technology infrastructure that is still a challenging, it's a challenging thing for us, especially in Iraq. This is what I'm talking about. Most people don't have access to technology, and even up until now, there are partial lockdowns and there are periodical temporal lockdowns. So just 2 weeks ago, the government of Baghdad decided that on Thursday, Friday, Saturday, and Sunday, there will be a lockdown. And then they will stop. They say okay, the lockdown will stop now. Then it will start the next day. So there's a lot of uncertainties for us. Planning is becoming very, very hard for us to do. Every time that we plan an event, they just say that we should stop people from gathering in the hotels or doing a conference about a specific topic, or doing a GBV awareness gather psychosocial session, even though we're taking the preventive measures. But sometimes it's really hard to plan because one day the city is not on lockdown, the other day it's on lockdown. The government did not plan that. Even we have access to borders because I am living in the Kurdistan region of Iraq, and we have a border in between the region and the rest of Iraq. Sometimes we are not allowed to get, we have a lot of our programming in the Iraqi side because there is more need in the Iraqi side, especially with the government closing all the IDP camps. This is very Iraq specific information. The Iraqi government closed all the IDP camps in 2020, and now they're all returning to their locations with the pandemic that's happening, and they do not have the basic needs. So this has created, again, how do you say, an increase in the GBV cases again, because people tend to be more violent. People tend to be people are in need. They don't have the basic needs that they want, the basic needs in their life. So there will be conflict if either it's going to be inside the family or outside the family. So even when we cannot have access to the other side, the other parts of Iraq sometimes because they close the border between Iraq and the Kurdistan region as well. This is something that's happening from time to time, and then they will stop. So planning during the COVID time is very hard. Another challenge is that a lot of people have lost their jobs during the pandemic, and they still have not been able to make up for this or get another job. So this is something that is continuing to happen. People are getting, the companies are doing, they're reducing, they're cutting employees. The government does not control that, and this will create more violent people. And it's this, what we haven't noticed, the people that have their husbands in the house, the husbands have a higher chance to be a perpetrator, and they have a higher chance to how to say apply violence to the family. So this is something else. And all this, that is the problem. And then we have, especially with the IDP camps being closed and the returnees going back to the areas right now, we have the need for hygiene kits, or we have the need for the basic needs. So sometimes, and the one other thing is that this year, the humanitarian response plan for Iraq was said to be the last one. And the IDPs were closed, the IDP camps were closed. So we have only 1 year, actually 9 months, to deal with the flow of all the IDPs into their cities. And then there are no humanitarian response plan for the next year. So that means that there will be a decrease in funding. And decrease in funding, that means decrease in services. And it's making everyone concerned at this point. We don't know. This is something else that is happening, because we are dealing with a lot of issues, not just GBV at the same time. And there are focus on everything right now, because of especially WASH, basic needs like food security, livelihood. These are very important topics in the areas where the returnees went back. And the returnees themselves are mostly engaged with those opportunities and have less time to talk about GBV. This is something that is a problem right now. I would say that these are the main problems that we're facing. The community engagement is not easy at this point, because everybody is looking for a job. Everybody is looking for a livelihood opportunity. When you say that I'm an organization that I work in GBV, people are not as interested as they were in a livelihood project, because they're in need for that.
Bryar, thank you. That takes me right to my next question, and that is that, you know, we're 1 year into this pandemic, and we know that recovery takes time, and there's going to be some very long-term effects, you know, around the world, and certainly in the humanitarian sector. So what are some of the long-term impacts do you foresee in our sector, and what would you hope to see from donors, governments, policymakers, you know, all the people making decisions around how to address these long-term issues? I think why don't you answer that question, Bryar, first?
Yeah, definitely. So one thing is that at this point, we have to be more proactive than being reactive. We have to work on prevention of GBV other than waiting for it to happen and then we'll react to it. Of course, reaction is very, very important at this point, because we cannot control it, but I recommend that we engage with the culture and try to do more of behavioral change than we are doing with case management. The thing that I've noticed is that we have more reactive programs than we have as proactive programs. So I don't think that as a long-term impact, because I'm just saying, like, this is not going to be the last pandemic. This is not going to be the last international crisis that's going to happen. What about the next one? Our societies are able to take the next pandemic or the next crisis or natural disaster. Everything that happens, every time a conflict happens, there is a bracketing in GBV cases, because we are not working on the behavioral change. We don't have the base. Our communities does not believe in gender equality, and that women and men can participate in rebuilding the country, in doing so many other things together, participating in the economy, participating in the peace reconciliation, participating in the government, in the being decision makers, participation in everything. So we don't have these basic needs. So GBV is going to happen again and again and again. So I think that what COVID did is one thing that it took us like 10 years back when it comes to GBV, because we were trying to solve a lot of problems together. But then there were so many other reasons for people to become violent. This is something that the corona did to us. This is a long-term impact that we did. But on the other side, it taught us how to deal with some complex humanitarian issues at the time that we don't have access. It taught us how to do remote assistance. It taught us how to take advantage of technology. It taught us like new ways to communicate with our beneficiaries, with the survivors that we're dealing with. But overall, it took us like 10 years back.
Thanks for that, Bryar. Yeah, Happy, I'd like to turn to you and ask you the same question. You know, what are some of the long-term impacts, and what do you think needs to be done about them? And I will bring up one of the things that Bryar said in his previous response, and that is the economic effects. You know, the economic effects of COVID have been really massive, and perhaps, you know, that's one of those long-term effects. But that or others in your context, that would be great.
Yes, the long-term effects, of course, like Mustafa said, it's not different here also in our community. It has taken us back. And of course, you know, the triggers or the contributors of GBV, of course, one of it is lack of course, basic necessities and all other contributors to gender. So triple escalation, which is really taking us back to step up and redesign our approaches in terms of being consistent with our message, and also engaging the one-on-one, and also as Action for Development, of course, intensifying our approach of model couple approach in GBV prevention and response at household level. Of course, the impact of teenage pregnancies, I think I have talked about this in my previous submission. This is something that we are going to live with for quite some time now, the adolescent girls that have really gone through this. And of course, due to the restriction on movement, nowhere to report to, some of the services, you know, are shut down, no one to talk to on what one is going through, and we are having so many adolescent girls with these unwanted pregnancies. And of course, the post, you know, pandemic trauma that is actually manifesting right now in our communities, having mental health, you know, having low self-esteem, of course on the conditions that the women and girls have gone through, and also denial of resources. Of course, this was a period when everyone was locked, you know, no movement, no income coming in. Those ones who had savings, of course, was utilized, and there was nothing now to feed on.
Happy, I think, did we lose Happy? Is that just me?
I think we lost her.
I can't hear, yeah.
Okay, I just want to make sure it wasn't just me. Speaking of technology, you know, it's not always perfect. So I wanted to go to you, Micah, actually. We're getting to the end of our program, and we want to take some audience questions. So Micah, if I can kind of go to you and just ask kind of a last question about recommendations, you know, based on the challenges that both, you know, through IMC you're still experiencing, the challenges you hear from these other panelists about how they're operating in the field. What are some recommendations do you have to address these issues both in the short term and the long term?
So I'm also having technology difficulties. I've shifted to my phone. No, I think so. I think that the other contributions were so on point. I agree, of course, that we've only started to see the effects of this. We know that gender equality has been set back everywhere around the world, in high resource countries as well. And gender inequality is, of course, the root cause of all GBV. So making sure that we maintain some attention to this, that this is a long-term situation that we'll be dealing with, is important. And I think the emphasis on girls is especially important, because we don't yet have any idea the consequences of the loss of school, and potentially that they won't re-enter school, at least not at the same rate as boys. So I think for the GBV sector to be really working closely with education and livelihoods initiatives, as well as sexual reproductive health, because we also don't know the consequences of a year of so many women being denied family planning opportunities. But with those points in mind, I also maybe want to emphasize a few positive things that I hope we can reinforce. One of them is that I hope we've more firmly established the fact that this type of emergency does bring GBV consequences. you know, that we actually saw that message pretty loud and clear early, even media attention. We didn't see corresponding funding and maybe attention in the global humanitarian response plan, but staying positive, I think that is something that we need to leverage and keep in mind. Another thing is that we've talked a lot in recent years about the importance of localization. And this pandemic has really pushed the localization agenda forward, I think, quite a lot. And we see more appreciation for the importance of working with local responders. And also, I hope, a lot more respect for what they can really accomplish. And then I think the third thing to emphasize is that while technology hasn't allowed everyone in all corners of the world to access services and information, most of us have better technology than we did, you know, 10 years ago. And I think seeing the community that's emerged from this, seeing 900 people on the community of practice sharing resources, sharing experiences from all different settings, and you know, freely contributing tools and advice to partners across the world, I think that it's helped bring us all a little bit closer. And I hope that that goodwill and spirit of helping one another continues, because in the field where we're all working, especially for local organizations, it can be a really lonely environment, and they're, you know, the only advocates for women and girls where they're working, and it's really important that they feel connected to colleagues, even if it's remotely.
Thank you, Micah. Thank you for those positive messages. Yeah, in a webinar like this, where we're talking about GBV and this spike and the rise and the challenges, it's important to hear that as well. Bryar, can you speak to that as well? What are your kind of takeaway recommendations?
Yeah, of course. This is one thing that Micah covered was going to be my main recommendation in these situations. One thing is that even us as a local partner, we used like sub-locals or like local partners that are smaller to achieve the results that we wanted to achieve. For example, when I'm talking about a community action group is not my organization. It's not the organization that I work for. It is a community-based group or a community that want to help produce from the GBV. I think that utilizing the local the local organizations and the local capacity to deal with these problems is something that I recommend, and I hope that this will, as Micah said, this will push the localization agenda forward. Even I work in Erbil in Iraq, which is in the north, in the Kurdistan region. But when I wanted to do a project in Nainawa or in Anbar or in Salahuddin, we always try to reach out to the organizations that are local to that place. Even inside Iraq, for us, they were more local than we were, and this coordination actually. Like there was a lot that contributed to our cause and what we were working for. Thank you.
So thank you for all of that information and all of your brilliant, really insights, I think, and insights from the field. I'm going to ask at least one audience question. There might be more, but one of the audience members asked about social media, and you know, you both talked about, certainly you and Happy, Bryar, spoke about targeted social media programs to address, you know, to give information awareness and social media campaigns. And the question is, did any of those social media campaigns increase the spread of misinformation? And, you know, were those problematic in any ways, or did they impact the provision of services? Did misinformation spread? Is that something you can talk to, Bryar?
Yeah, of course. One thing was that I don't think that the campaigns that we were doing were mostly like we would send it out, contributed to misinforming the people that we were targeting. I think that we tried to actually change the misinformation that they have received from other people on social media, because especially when we don't work in health usually, but during the corona situation, we had a huge campaign for our targeted beneficiaries or our survivors. We had a huge campaign on GBV awareness, on COVID-19 awareness and prevention, and how what is right, what is wrong. This is a myth. This is not a myth. We were coordinating with the health clusters to remove these misinformation. I think that I understand the concern that you're talking about, but in our case, we were mostly trying to communicate what services do we have, and then the caseworkers or social workers or the people that were the frontliners were talking to them to make sure that they don't have any misinformation. So we did not put a lot of information out there that people would depend on and not. For example, there's one specific point that needs more elaboration and someone might not understand exactly that point. So that's why what we tried to do was trying to promote our hotlines, our communication channels, and how people can come to us for questions and how can we receive survivors. And if that answers your question.
Yeah, I think so. It was Nadia's question that I think, came from the talk about social media, because social media has such a potential for misinformation.
We were trying to do an adverse current of what was happening with the misinformation. We tried to fix that, and we made sure that we don't say anything that needs more elaboration. So we just communicated the numbers, and people were calling in, and it was very helpful.
Great, thank you. Micah, do you have any comments on this or? No, okay. So I want to ask, do we have Happy back? I don't think we do, but I want to ask one final.
She's here.
Oh, she is, great.
I am.
Happy, you're there, great. Sorry, I don't see my so yeah, Happy, maybe you can speak to, let me go back to the last question actually, not the social media question, but the one about recommendations. What recommendations do you have going forward, based on the challenges you're still experiencing? Recommendations for anyone, certainly for donors, but also for anyone else.
Okay, thank you. One of the few recommendations that I would really put across is institutionalizing or having an emergency fund to respond to such elapses of the pandemics that may come, of course, unexpectedly. And instead of really having the shutdown of all, some of these services that are beneficial to the GBV survivors, maybe we can have, a fund that we don't need to really justify why you need this, why you need the PPEs, but there is a certain fund that is there to respond to such pandemics. Secondly, is to really have in place the regular sharing experiences among the women-led organizations, of course, at national level as Action for Development, but also at community level, there are those women-led groups, as well as the donors or the development partners, to share field-based experiences that can inform decisions at those global platforms, and would really recommend that these experience sharing sessions would be regular, so that some of these can actually be integrated in the decisions that are being taken at that level. And also another recommendation that I would really put forward is strengthening our community structures or the community networks, because they've really been helpful and useful in responding to some of these cases at community level without our physical presence. So we'd really have to engage more our community networks, and also having tailored approaches targeting adolescent girls in school and out of school, as well as wellness and safety sessions for GBV actors, so that we keep, revamping ourselves and motivating ourselves on what we need to respond to as service providers. Thank you.
Happy, thank you. I think that was we have a couple more minutes left, so I'll open it up and keep the chat open for questions. But I think that was a perfect way to even end, because I think you mentioned some of the very key recommendations, experience sharing, which Micah mentioned, you know, even through the community of practice, and you know, how local organizations and international organizations can share best practices and really come together and have done so even in this pandemic. Another thing you said is that, you know, for the next crisis, Bryar mentioned that this is not the last one. This will not be the last global emergency. And so in the next crisis, we need to make sure that GBV service provision is seen as essential, and that services do not fully close down, because as Micah has said throughout this session, you know, there's something essential and different about in-person services than all the adaptations we've made and done so well. And then finally, you mentioned the community networks and community-based service provision, and community-based providers are really important, and we need to strengthen those. So I think those are some really key takeaways. And I just wanted to, you know, kind of also end on Micah's positive note about some of the ways we've seen these adaptations improve things. And I think that despite these issues of GBV and gender equality going backwards in some ways, you know, there's really dedicated people. I mean, really dedicated people, not only yourselves, but the people working with you, as you mentioned, are so dedicated to providing services and changing the situation for women and girls worldwide. And I think it's important to note, because I think a lot of us were focused on International Women's Day yesterday. So just important to note that we're following that day, that really encourages us not only to see these challenges that we've all mentioned today and how COVID has exacerbated some of them, but also see, you know, the way forward. And that's really what this webinar was about, is kind of seeing the way forward and seeing how you all have adapted and taking those adaptations and recommendations forward. So thank you everyone for joining us. I think we're gonna call it a day, but thank you for joining us from all over the world. And
sorry, Devon, can I add one thing?
Yeah, please.
Yeah, I'm so sorry to keep everyone, but I noticed that there was a few questions in the chat that I think that we didn't have time to cover, and I want to just take 2 minutes to answer them, if that's okay.
Sure.
Yeah, so there's Nishaba from Mercy Corps had a question about, I think it was about like psychosocial support if it's working remotely over Zoom or Google Meet. I would suggest that, yeah, if you have the right people that are have the experience of doing these sessions online, that doesn't require any materials or anything, I think that is very much doable. But you have to use the services that are, you have to think about the technological side as well. You have to use services that are faster than the others, so that people can have like engagement. It's like Google Meet is something good, and it's not very complicated. You can use it and people can easily join you. It's easier than Zoom for sure. And never put registrations or anything on the psychosocial support side, or they do not know, because there is no technological background. Most of the people that we are working on, this is something that I wanted to say. And there was something else about what safety measures were adopted. Of course, like hygiene, as I said, preventive measures, social distancing for all the frontline staff. And what did we do to access people that are survivors that are with the perpetrators inside the house? This is something else when we took advantage and utilized the community action groups. So they were inside the communities and they actually knew who is being violated against and what are the gender-based violences that are happening. Most of them, they were aware of it. They would reach out to someone, some old woman in this community that we were in contact with, so that we could have access to these people. So again, we utilized the capacity of the community action groups or the community-based people that we had inside inside the communities that we were targeting. So they would usually go to someone that we know that old woman is very respected. They would say like, my husband is hitting me, or my husband is like, there's like verbal violence, there's like physical violence, there's sexual violence. They would talk about it and then they would refer it to us. That's when Safe Referral came to work. And the last question is that, did any of the organizations provide services for their own staff for their personal well-being, since they were in the lockdown, facing triple burden, ongoing a lot of anxiety, and facing GBV at home? This is something else that we had to focus on very much, because we have weekly meetings and then we have surveys so that we ensure that well-being of our staff. And since they were at home dealing with a lot of people online on the phone doing case management, they needed some psychosocial well-being themselves. They needed to get out of the house or to take a few days off or go for a group activity or something. We were trying to provide them with these services so that they would be active, and they would provide like quality services to the people that we're engaging with, because engagement is online is not easy for one person. So imagine this person talking to someone over the phone for like 8 hours, and engagement is not easy at all. Thank you so much. That was the last question.
We actually have one more point in the chat. We have someone who's sharing a survey. Let's see, there she is, Elisa. So for anyone who wants to see, they're conducting a survey to collect more people's thoughts on these topics. So feel free to take a look at that link, and you can see what the survey is about and see if you want to participate. But again, thank you so much. And thanks, Bryar, for recognizing those questions and getting to those, because I think it's important when we have each other all here together to address as much as we can. But thank you again, and happy belated International Women's Day, and keep doing the work you're doing, and please keep communicating through InterAction and your other partners, and also the community of practice. So thanks everyone, and have a good morning or afternoon or evening or wherever you are. Thanks.